CME on recent trends on neuro rehabilitation. May I call upon Shrutina for the invocation.
मूषिकवागनमोदकहस्त चामरकर्णविलम्बितसूत्र वामनरूपमहेश्वरपुत्र विघ्नविनायकपादनमस्ते गजाननं भूतगणादिसेवितं कपिस्तजम्बो परसरपक्षितम् उमासुतं शोकविनाशकारणं नमामि विघ्नेश्वर पादपङ्कजम् एकदन्ता उमासुत विनायको भज गजानना एकदन्ता उमासुता.
Thank you, Shrutina. That was wonderful. I welcome our CEO for today's grandiose occasion, Rajneesh Menon sir. I welcome Dr. Deepak for today's honorable speaker. I welcome Dr. Ramesh, today's another honorable speaker. I also welcome a management staff, Saravanan, our sales head, Darshan, our deputy manager, Kuldeep, again from the sales, and the delegates from all over Bangalore who have come. Thank you so much. And last but not least, our own team, the therapy team of Sukino. Thank you all for coming. Have a wonderful day. Over to you.
Light symbolizes knowledge. May I call upon the dignitaries to kindly come forward for the lamp lighting ceremony.
Following Dr. Ramesh from Ramaiah Medical College, Department of Physiotherapy. Following him, Dr. Deepak, a very renowned consultant neurosurgeon. Sir, will first felicitate Dr. Deepak. Photo. Just we should do this.
Thank you, CEO Deepak, Dr. Ramesh, for coming down here and sharing the knowledge. This particular session I look at as a cross-pollination of ideas, of expertise, skills. And when I say cross-pollination, obviously you're going to listen a lot from the experts and the expertise of Dr. Deepak and Dr. Ramesh. But at the same time, I expect each one of you also to ask questions and share your experiences as well. It's very important that knowledge sharing is not just hearing to somebody, but it's also debating, discussing, and asking questions, the toughest things that you have faced and how we want to go about it. Sukino as a company was set up not just from a medical recuperation perspective, but the goal was very simple. We believed that medical recuperation and rehabilitation will go hand in hand. I think one of the first few movers in this space, we recognized that 50% of clinical and 50% of therapy is extremely important. And you play the biggest role in ensuring that people get back to their activities of daily living. Now, my endeavor and my interest always has been to ensure that your knowledge is always kept up to date. One way of keeping the knowledge up to date is by you handling new cases per day, getting a chance to speak to the treating doctors through your department heads. And secondly, one of the ways in which I can improve your skill is by ensuring that we conduct similar events, such events, where all of you can listen to the expertise and discuss and debate. So make the best use of it. And once you've made the best use of it, for people who are coming from outside of Sukino or people who do not work in Sukino, this is the best chance to see how a proper good rehabilitation center should look like. So please go forward, take a look at our center, talk to our doctors, talk to our patients, talk to our own therapist over here, and understand better and spread the good word about what we all do in this community out here. So all the best, enjoy, and keep sharing and gaining more and more knowledge. Thank you.
Thank you, sir.
Since 80 years. So today we are dealing with one of the important aspects in physiotherapy itself, like the head injury, and the worst disability it causes to the human being, that is causing you the chronic disability, and how the neuro rehabilitation can be made. So for example, any head injury, if you take it, if you understand the magnitude of the problem, then only you will get you will know the necessity of the need of the rehabilitation. So this is 60 million per year. This is the world data. So this is 60 million per year, the head injury cases we have to note. So it may be because of the fall, it may be because of RTA, because of assault, various other causes. This thing. And another most important aspect is the age group which it involves. Mostly the 44% is in the age group of 20 to 40 years of age. This is the age where majority of the workforce will be in this age group. So if you compare with the spinal cord injury, it is 20 times more, and the death rate is 3%. And the most important aspect is more than the death rate, it is 20 to 50% of the disability it causes actually. So each person. This is the general scenario if I take this thing. I'll just give you a brief history of one case actually. Here is a 32-year-old male. So he has done all the studies, he has done the Bachelor of Engineering, he did MTech, he did MBA. So he has a passion of riding a bike actually. So he has become one business head in the company. And he's recently married, and the plans also starts actually, he wanted to buy a new home and new company, this thing. So he met with an accident, and he had a left temporal and parietal contusion with diffuse axonal injury with IVH. So he need to be hospitalized for 3 months. So after 3 months, he was basically he was in a coma stage, and then he regained consciousness over a period of a time. After 3 months, he's still aphasic, he's irritable. So he had a behavioral problems, mood, cognition, particularly memory, attention, executive function is not there. So all it caused was another monetary burden it has caused, hospital charges, post-hospitalized rehabilitation cost, and again all this, because of this, now he can't do his function as that. So whatever he has studied and everything, he is not able to function normally. So family is in depressions, so monetarily also they are in a burden. So if you take a particular case, so overall if you take, even though it causes 20 to 50% disability, for this person it is 100% disability. Whether you take it as a monetary wise, whether you take it as a physical disability with this thing, even though he may not have a physical disability, so his mental functions are not that much enough to do the particular job. So if you take this rehabilitation part comes over here actually, how to improve him, to make him as that of earlier so that he functions normally. So this is a brief, the chart showing how the impact, head impact, how we do this initial ATLS, this thing. So we will concentrate only on the rehabilitation part actually here. See, whenever we come to the rehabilitation, so we face so many problems because of interdepartmental coordinations actually. It's not a one man's job, you do all the work by alone, this thing. So it requires as per the physician, not only the physician care, physiotherapist, there is a speech therapist, occupational therapist, psychologist, psychiatrist, everybody should be involved, and there should be interdisciplinary measures. So there should be set of rules to be formed, this thing. So for a complete neuro rehabilitation course, see, whenever we aspect is of mainly of the physical things actually. For example, weakness is that we want to develop the weak, improve the weakness. It should not be limited to that of a physical in nature actually. So ultimately, we need to improve his cognitive functions, communicative skills, and also this one personality changes. We also will face with like some urinary disturbance, bladder control. We have the whole head injury will have the problems, other issues like swallowing difficulties, this thing. So this also needs to be like attended to during the rehabilitation therapies. So all this totally like the thing, like it's a kind of a social burden to him. Like he will not be able to attain the social activities till he becomes completely normal. So first like this thing, like usually the as a protocol, like the rehabilitation is nothing different. Like post-hospitalization, it should start from the beginning itself actually, like with injury. So whenever you are called actually, like as a physiotherapist, as a speech therapist, whoever it is, like they has to assess their like what are the impairments. So okay, so if you don't assess properly, like you like each patient is a different actually. We can't generalize the plans and everything to according to this one. So for example, like if like what is the weakness, what how can he able to communicate with us? So some of the head injury patients, like spinal cord injury and head injury, there is a difference is this one. So in spinal cord injury, at least you can able to communicate with the patient properly. Here what happens is like the communication is the biggest problem. So you have to assess by yourself. Impairments also you need to assess by yourself. So how much is how he will be able to participate in the activities, also that also matters. So then the other contacts actually, the other contacts in the sense of like patients, like monetary wise and this how much their priorities they will give, all depends upon the your assessment regarding the rehabilitation. So, see, like whenever there is a rehabilitation, there is certain things which you have to see. For example, like we have seen, like while mobilizing, there is a shoulder dislocation happening to the patients. This thing. So, like rehabilitation should not be a burden, like causing another complications actually. So, rehabilitation has to be done with certain this thing care. Like restoring function is important, and also the restoring the occupational functions. So restoring the function is like improving the limb movements. For example, sometimes what happens is like we can't able to restore the function of the right limb. So at least if left limb is working, so we should make help of it, and you have to be like writing it the left hand itself. This we call as a like more of occupational therapy kind of a thing. So, and depending upon the thing patient needs, it has to be channelized actually. And see, reassessment is means like reassessment in the sense like every like a month or 2 months of this thing. So how the improvement it is there, like what best, like what advancement you have to make. So you have to adjust the rehab plans also, and how he is able to work on his like whatever the work he was doing, was he able to do that? For example, if he is a driver, we can't send him to driving this thing. So so other works he can do that, this one. So total care if you take it actually. So all this needs is a particular passion for him, for the patient, this thing. So it should not be related, he comes, so you did this an exercise and you sent him. So like if you think of whole as a whole patient as your like a kind of if your brother or if your sister is in that position, how will you take care? So that passion if you develop, I think like then the whole thing you will have a bigger picture rather than treating him as a one patient. He has come and you finish this thing. So there are certain specific rehabilitation problems actually. So, like for example, like severe physical disability. Obviously, like whenever there is a motor movements, we call it as like So we assess the grades like M1, M2, M3. This is the motor grades. Normally it will be M6. Like M6 means like, so he can able to communicate, he can able to do the things, not this one. So for example, the patient is M2 or M3 status, we call it as, where they will not able to understand your this thing. So there is another problem comes is like, especially if the movements have been not done, the joints will become almost like a kind of started to developing deformities, this thing. And another problem is whenever there is a head injury, there is what we call it as a spasticity development. So the major thing for the this one problems is whenever there is a severe physical disability, obviously the rehabilitation course also will take time. Another part we have to look into is the nutrition part. So usually there will be an hearty feeds actually. This hearty feeds so may not be much of like nutrition as of a normal person. So if we channelize the dietitians properly, so and you monitor the weight, particularly this one, how is the first sitting, second sitting, how is it, this thing, his weight gain and all this. So if you will come to know the nutrition part also, this thing. Then the pressure source. So pressure source, it's like it's a part of, as we told, like position changing, airbed requirements. So if that is not taken care, that will lead to infections. So again, so whenever there is an infection or anything in the body, so usually what happens is like their overall development also comes down. This one. So and another urinary incontinence. So urinary incontinence. Like even though for the females we usually catheterize, for the males also we catheterize, but if you keep it for the longer time, so there is a problems of chronic infections. So chronic infection is also main issues, this thing. So as I told you, like infection is one thing which can like whatever the improvement which happened in 1 month will be like patient will be going down by within 2 or 3 days with this infection. Communication problems, as I told you, like this is a problem with the head injury. So we feel like spinal cord injury patients can be better treated compared to the head injury patients because of these problems actually. And in the communication problems, even the left and right brain injuries also, it is different. Like we can see that like right brain injury, if it is there, where the most of the this thing, we are right-handed persons. So our motor cortex, we are like speech, this thing, all will be in the left side. We face a difficulty, those who have a left brain injury. So, and as I told you, like another is this cognitive and intellectual problems. Cognitive, even though communication is good, like the thing, so there might be the intellectual assessment we couldn't do because of this issues itself. They may not be able to completely do the functions normally. Just brief introduction about the newer modalities. I think like Sir will tell you all about the physiotherapy aspects of rehabilitations. I'll be concentrating on only the things like what we are like newer aspects which is coming to for as a we to prevent the secondary aspects of injury. This is one thing is like hyperbaric oxygen therapy. So where we give 100% oxygen with that high pressure, like 1 atmosphere thing. So this will help in like suppressing the inflammation, apoptosis. See, where there is in head injury, there is a primary impact and there is a secondary impact actually. Primary impact means like whenever you have an impact, so there is a certain part of the brain gets damaged. There is another thing called as secondary aspect. After the particular neurons have been it's damaged, so they themselves, when they die, they release some amount of chemicals, so that can damage the further neurons actually. So to prevent those aspects, this therapy, like what we have seen is like primary impact. For example, like some 5 centimeter of the brain has been damaged. So this is at the day 1. Okay, so if you see at day 8 or something, like what happens is like with the 5 centimeter, the brain which is damaged, it's gone. And then comes is like almost like surrounding tissues, the lower down also, where there is a connection, like wire connections. For example, like This wire is there, like top, this thing. So in the brain, what happens is, even though the main thing is damaged, the wire also gets damaged. Okay, so this is because of the certain chemicals which is released from the brain cells actually. To prevent all these things, so this is one of the modalities which is being tried. Second is the stem cell therapy. Stem cells, as you know that actually, like you maybe heard about this therapies which we use it in the spinal cord injuries. So spinal cord and the brain, there is a difference. Is like in the spinal cord, at least like there is less chance of infections when this thing. So here, we have like this has been tried, but like is still in a phase of not much improvement we can see in the currently in the brain injury cases, but still. So the stem cells, you can see that. Yeah, anything. First one. See, this stem cells can change over to any type of the cells with particular of growth factors. So if you like, for example, like if you wanted to convert into the muscle, there is a muscle growth factors which are there. So which we add, if you give muscle growth factor, this cells will turn into a muscle actually. If a nerve growth factor is added, it will turn into a nerve cells. But this is in a laboratory wise that can be tested. But the similar thing happening over in the brain cells is little bit difficult actually. So even though we had a cells, but the cell nerve growth factors are less in the brain, and this causes the problem. These are non-invasive brain stimulations actually. So non-invasive brain stimulation, you pass an electric, we call it as a transcranial direct current stimulations. So like now what is happening is there is a wire, but there is no switch in the brain. So you stimulate that nerve actually. You stimulate that nerve. By stimulating the nerve, you are improving the muscle functions. You are improving this one, what we call it as like electrical activity in the nerve. So this has been tried, like not as for a paralysis or anything. So for the some of the aspects of like altered consciousness, this thing, depressions, and heavy spatial neglect, hallucinations, depressions. So basically, kind of like in kind of psychotherapy kind of here. So this has been like in a channel actually. So not much improvement we have seen, but some patients like some 10% improvement, 20% improvement over a period of 2 to 3 months. We have seen that. This is magnetic stimulation. This is also like here also we have excitatory and inhibitory activity. We can do it actually. There are two types of nerves we see: excitatory nerves and inhibitory nerves. So this is also helpful in depression, memory deficits, and also in attention deficits and tinnitus. The same. This is a final this thing like audio-visual and game-associated functions into trainings. So overall training, for example, like that weaknesses now improved. For example, 90% or 80% it has improved. See, gaming is one thing which requires like extreme concentration, extreme kind of coordination of all the muscles. This thing. So this type of reality, this thing, like it helps in overall functions actually, especially in case of memory, attention, visual perceptions, audio perceptions. So as an overall work-related occupational therapy, it will help. A limb and organ function reconstruction. This is like for a particular, for example, swallowing difficulty, it is there, speech problem, it is there. So where we can give, like for example, for the vocal cord, this thing, like directly you give the stimulation. So you do all the work-related exercise. For example, like if he's a mechanic kind of a thing. So whatever the muscles required for the stimulation, this thing, you give it at the stimulation, electrical stimulation to that thing. So you ask him to do the functions, and you give the stimulations to the muscles. So overall, like activity-oriented stimulation, particularly, this is also one of the newest things. Last and not the least, actually, that psychotherapy, this one, because like, see, functionally, as a this thing, person will not become normal, even though his power becomes normal. Power in the sense, like, as a physical, he can able to lift everything. So unless his emotional and behavioral problems are taken care, so he will not be a function in a family or anything. He will not be socially kind of gets adjusted to the environment. So there are certain like psychotherapy we can do it, and music therapy also. This all emphasize overall to the like in the initial phase we may be considering more of a physical and this thing over a period of a time, like whenever he becomes more communicative and this thing, we can deal with his emotional and behavioral but therapies. So finally leading to a good occupation he can do it by himself, so taken care by his family and his needs. And that's it. Okay, thank you very much.
Thank you so much, sir. That was one of a beautiful speech. The session is open for the doubts. Any questions? Yes.
Good morning, sir. I'm Nitin. I'm head of in charge for Sukino Kormangla. I wanted to know the rehabilitation plan for the case that you presented initially for a 32-year-old male. So, what was the rehab plan? What was the final outcome?
See, like now he's doing good actually, in the sense like emotionally and this thing. Like still there is some problem with the depression aspect. This one. So initial rehabilitation plan was like when he was in the hospital, like similar like physical exercise. This one music therapy, psychotherapy was going on. So like at most like any as a something like he will not become 100% kind of a normal this thing. Still he has some emotional aspects problems, like suddenly he will get depressed this thing. He's on medications. So if you say that he's not able to work as of earlier, but he's able to lead his own life this thing.
Okay, how long it has taken for this journey? Or
Like 6 to 8 months it has taken.
6 to 8 months.
Yeah.
Okay. And one more doubt is about hyperbaric oxygen therapy, which you said about. So, at what point of time do you start with hyperbaric oxygen therapy?
In initial phase itself, actually. In the initial phase, not in the later part. Later part, it's of no use actually.
Okay.
This one. So, like as we tell this thing, like earlier, there is some change in the concept. There is some pros and cons of this one. So, hyperbaric oxygen therapy in the initial phase itself, like there is a primary assault. So whenever there is after the primary impact it is there is a secondary. It happens usually 24 to 48 hours, and by the third day it will start be more. So whatever we see that head injury, right, to get stabilized, it will be like some 10 days. The same. So for example, if you follow with the CT scan, one clot it is there, like brain contusion it is there. To get resolved, it will take 1.5 months. This one. So we are more concentrating on the early phase itself. It's not like we are the same. Like some after 1 month or 2 months, we are going for this therapies actually.
What I wanted to know is that in your personal experience, patients whom you have given hyperbaric oxygen therapy and whom you have not given, have you seen any differences in their rehab final outcome?
Yeah. Actually, as I told you, like there is a pros and there is a cons actually. This thing, some think that by giving the baric oxygen, so might be a lung damage also. This thing. Then what we do is like this is not strictly followed. Currently this one. So what we do is like in the initial phase, like current we do is like, for at least 2 to 3 hours, we give the hyperbaric oxygen and then we'll maintain it at 40% kind of a thing. So it's all individual based, this thing. If you take a statistics of this one, like somebody claims it's very good, somebody claims it's of no use, but we feel that like we don't want to give it as a full thing, because like there is a aspects of some lung damages also happening because of hyperbaric oxygen. So we want to keep it as a kind of intermittent therapy rather than continuous therapy.
Thank you.
Hello sir, I'm Subbu and I'm from a wearable sensor company related to rehabilitation and movement health assessment. So I have a question, two questions in fact. One is about neuroplasticity. So how do you utilize the concept? Because you have mentioned you utilize neuroplasticity concepts.
Concept in the sense like, for example, like as I told you for this thing, like there is a certain speech aspects actually. Like there is nothing like there is one part of the brain, if it gets damaged, this one, our speech is gone. Okay. So, but usually they are focused on the left side. Okay. Okay. So some of the aspects which may not be working over a period of a time by stimulations, if we give, so like stimulation in the sense not like some electrical direct current giving this thing. So there is a other part actually will be taken care. For example, if you repetitively do, for example, if you don't able to tell like certain A, B words or C words kind of a thing, repeatedly making like some music therapy, you give kind of those like similar to sounding to that. For example, C you can't pronounce the C. So you give a music therapy, you like stimulation kind of a thing. Plasticity is nothing but like other aspect of the brain taking over the function of which is original. Okay. This thing. So we like over like if you get a CT scan done, that part of the brain is damaged. Okay. Okay. Structurally it is damaged. Okay. Function has to be done by the other this thing. For over a period of a time, like if you map with the, there is a what we call it as MRI with the specifically activity. This one. For example, if you do a speech, for example, if I am talking in this thing, if I get an MRI, there is a certain part of the brain which is more active. Right. Right. So, for example, like that part which is damaged, this thing. So if you get an MRI, like even if I want to talk or something, that part is already damaged, like that activity is gone. Right. No, for example, over a period of a time, like if you give continuous stimulation on this thing, there is a chance that some other neurons taking the function of the present neurons.
Okay. So you try those modalities if it can be transferred to other areas?
No, we can't do like that actually, but it has to be done by itself.
Okay.
The thing, but by stimulating it, as I told you, like direct current stimulation can also be done. Even the magnetic stimulation can also be done actually. So those stimulation, like it's not 100% that they will be doing it actually. Especially for example, like if you take for 8-year-old or 10-year-old child with head injuries. Over a period of a time, like after 20 years or something, even though their left part is damaged, they will be doing absolutely fine.
Compensating in some way.
Yeah. So neuroplasticity is like for the children or something, it is very helpful for them. So over a period of a time, they do pretty good. Comparing to the 50 years or 40 years with having a head injury, so their function after some like see. If you assess at 3 years post-head injury and 10 years post-injury, they will be remain same actually. Okay. This thing, there won't be much improvement if you can see. The same, that child had a head injury at 80 years, so he was like bedridden for a long time. At 3 years or 4 years, child is much more improved. And if you compare that child with another like 10 years down the lane, so child will be very much this thing, like very much socializing, very much this thing. So intelligence will also much better. This thing. So if you compare their MRI this thing, if you see that the brain which is damaged, it's damaged, but the function is being taken care by the other areas. So like it's an adjustment by the brain. So we don't sell regrowth of the neurons.
Yeah.
There is nothing called as regrowth of neurons. Even though we use stem cells, as I told you, like this thing. See, we have a cell which can get converted into a neuron, but taking the function of the particular this thing is still it's not in our hand. That is the
Yeah,
problem
yeah.
actually.
Yeah.
So we can give nerve growth factors, we can give neurons to develop, but neurons has to take that function. So it's not in our control, and it has a very complex things to happen. So even though nerve regeneration we can make it, but it won't take up the function.
Yeah. Thank you. Thank you. So the second one is about assessment and reassessment. So I had a question about communicating this assessment part. So when you communicate the assessment and then some time passes and then you reassess, there is an improvement or no improvement. When you communicate, is it having any impact on the confidence level, at least for this person or any other patient that you have dealt with? So is it impacting their confidence? Okay, I'm improving. Okay, I think I'll put in more effort. Or
Yeah.
what is the impact that is having?
Yeah, it will have an impact actually. You see like for example, like each time when the patient comes actually, he want to show that I'm improved. Yeah, by himself he will tell that this thing. So next you give a certain next level of activity to do him. This one obviously like he will be more enthusiastic to learn new things. He want to show us like for example like see like. For a completely severe disability, as I told you, like it's not in our hand actually.
Right.
Okay. For there are certain functions like hemispatial neglect is there. For example, like hemispatial neglect is for example, what they do is like if you ask them to shave actually, they will shave on one side.
Mm-hmm.
Okay. So if they want to comb, they will comb on the one side.
Oh.
So they can button on the one side. They can't button on the other side actually. This thing. See, these we call it as like there are certain aspects. So he, as a person, he may looks normal kind of a thing, but he will not be able to doing all these things. Okay, if you if I ask him to write a clock, actually, he will write 1, 2, 3, 4 to 6. He will not be able to write 6 to 12. Okay. So if you ask him to draw a rectangle, he will draw a curvy line on the one side, and he will put a clear diagram on the other side. So these are the aspects actually. And if you draw a line and you ask him to mark a midline, something, he will write it on the one side. He will mark it as a midline. So this aspect actually. Now, if you ask him to do consciously, this same aspects, if you do consciously, for example, see, this is not the midline. This is the midline. Okay, so he will show that aspect like over a period of like 1 month or something. You will be able to change the things actually. So you will start marking on the midline itself. This thing. So you will be able to draw a clock over a period of. These are like certain functions. If you ask him to do, so over a period of time he will do that actually. But if you tell them, like for example, like he has some weakness. This thing. Now, directly if you go to those type of functions, then he will feel depressed,
Right, not being able
so,
to.
yeah, obviously you will not able to do that this thing. So if you should not be giving a task to do at a, this one, those which are like more of complete function related memory attention which is required. So it has to be given at a later stages.
Sure.
So that is like you assess him, like you give him a task so that he do. For example, if you like he has come in a wheelchair and you ask him to do like you do just stand and with the support and you start walking.
Yes.
This one. That he will be able to do that.
Okay. Okay.
So this one. So once he starts walking, then only you can tell him that you leave one hand, you leave this thing. So that the basically kind of these aspects are there, like there is nothing like book format.
Of course.
So obviously you see the patient and you recommend this type of exercises accordingly.
Okay. So such communication definitely has impact in terms of growing their confidence. And
Yeah. I think like in the initial part we have to more rely on the attendance actually.
Mm-hmm.
Okay. So for example, especially like this thing like it's related head injury, stroke or anything, right? So we face more problem if there is any of having a left brain injuries. So like we can't able to communicate properly. They are aphasic actually. They can't address their issues also. Right. This thing. So like sometimes what happens if they have breathing issues, something like this one, some pain, this one. You usually while mobilizing or something, he will bedridden means like you know that a normal person if he lies down for 5 days. So will he wake up with a normal kind of like 5 days I've taken rest. So it's a severe painful after 5 days. See, like this is like now you expect him to, he's lying down for like months and this thing. So he will have his own problems actually. That are problems itself, he will not be able to communicate with you. Becomes difficult actually. But see, like if you take like if there is a one good attendant, if it is there, and if you teach him properly in this thing, so this aspects also has to be taken care of. So I think they will do that. I think. All right. Thank you.
Hi sir. Sir, I have 3 questions, sir. Sir, in normal head injury patients, we commonly see myositis and heterotropic ossification. Sir, commonly we get this because of doing vigorous physio or vigorous massage techniques. Even though we are not doing this, maximum head injury patients, full body comparatively lower joints, there is a chance of getting more myositis. Sir. What is the reason for getting that? How can we treat it conservatively other than surgery?
See, like any like for example, like a patient if he is lying down, as I told you, like for normal person, if he lies down for 5 days, so muscles will get atrophied, so tendons will more stiff. This thing. So you obviously, like for example, if you take elbow joint kind of thing. So if a person keeps it like this, the almost joint starts like ossification, becoming like a bone kind of a thing. So initially what happens is like muscles will get atrophied, tendons will become more kind of stiff. So then comes the joint part, the joint of which where it will come down. Like treatment aspect, if you see, it's just like if they take care of the proper the thing, like to decrease spasticity, we use baclofen. This one to decrease the spasticity, so increase the movement. That is the treatment. Other than that, it's nothing of it.
Sir, when we give baclofen for the spasticity management, sir, commonly baclofen, how it acts, it will block the calcium, sodium channels and it will open the chloride channels. Sir, in this situation, if we do therapy, we commonly for spasticity we do sustained stretching and all. Is it useful for after taking medicine or before taking medicine if you do the therapy? What will be the better, sir? Before taking the medicine, sir.
See, like there is 2 problems with the baclofen. So, for example, like why our body will become stiff, like with this thing. That is more important. So, spasticity is nothing but it's our body protection to reduce the movements. Okay. So, for example, main thing if you notice, you will have a stiff knee joint actually. So, person with stiff knee joint will able to walk actually. This thing, like after giving baclofen, he will become like this. So he will start falling down actually. So there is a problem with the stiff. Like if you have a right, like the dosage, if you give it rightly, and then you assess. I think you can give baclofen at a lower dose. You decrease the doses. Like for initially, if severe spasticity is there, you increase the dose like 2 times a day, 3 times a day. You give it actually. So and then. Basically, we have to do the movements. Obviously, this thing. If you give more dose, then it's a problem. So earlier he was walking, he was not able to walk after baclofen therapy, and he will be more fatigued because baclofen will be acting on all the muscles, even the respiratory muscles actually. So we should not be too much rely on the baclofen this thing. So keep it at lower dose. So I think like heat therapy, all will help in relaxing the muscles. So at that time, I think whatever you do after baclofen itself. Actually. Before baclofen, if you use like there is muscle tears and all these problems will be there.
So one more thing for diffuse axonal injury. Do anything particular grade, sir? Any grade scales and all? Commonly for head injury, we have GCS scale. Based on that, we do the therapy.
See, microscopically, we have like 4 grades. We do it actually at this thing. Like for example, if it is it's only in the brainstem or like from the brainstem there is a corpus callosum or like whole brain involvement. If it is there, that is also a different like severe grade of diffuse axonal. But diffuse axonal like usually they do pretty good. This thing. For example, like unless it is not severe enough, so if there is no even the brainstem involvement, if it is less, usually within 2 to 3 weeks they do pretty good diffuse axonal injury patients.
Sir, one more last question, sir. Sir, in the stroke, comparing, sir, they have two types of strokes, anterior and posterior. In the anterior means like all the cerebral cortex lobes will be involved, frontal, parietal, occipital, and temporal. Comparing to brainstem area, sir, with art syndromes are there, medullary artery syndrome, Pontine artery syndrome.
Yeah.
Sir, in this medullary artery syndrome or Pontine stroke, anything, sir, a full body will be affected. All frontolateral hemiplegia will be there, but upper limb will have good recovery. But in the anterior, they will be having good recovery in the leg, but no proper movements in the hands. But in this syndromes, medullary artery, Pontine strokes, there will be low tone in the lower limb. See, why that particular stuff?
See, like our brain, this thing, right? So how is it actually? So how the representation is from the opposite to this one. You see, our legs are represented at higher level, and then this we call as homunculus.
Homunculus, yes.
This thing. So how the pattern of homunculus it is there? This one. Like if you see that the anterior vessels which grows this one, usually the supply will be more towards the hands compared to the legs. You see, for sometimes like those who have stroke here, like in the stroke, it's more involves of limb, upper limb rather than the lower limbs. Like cerebral strokes which we see, for example, MCA, like middle cerebral artery stroke, it is there or something. They involve more of hands rather than legs actually. Like for example, he will be walking but with hands like this.
Yeah.
So that is the thing. If you coming to the brainstem actually, the brainstem pattern, if you see that the area which is involved, it will involves more of legs rather than hands. The thing. So wherever there is infarct in the brainstem, we see that more of the limbs, if it gets involved, so there will be more damage compared to the hands.
Sir, in the brainstem area, there is one area called red nucleus. It controls the full tones in the full body. Anything particular drug to stimulate that, sir?
No, there is nothing like that to stimulate or anything. See, red nucleus area, like if you think it's in the millimeters. Okay, so there is a, like for example, whenever there is red nucleus is involved, the thing or any like brain basal ganglia regions are involved, there are drugs actually, like whatever, like you can see that Parkinson, this thing, even the chorea, hemiplegia we call it as this thing. So there are certain areas we can stimulate actually, but they are very costly. Like deep brain stimulation will cost some 10 to 15 lakhs. This thing. So like in this criteria, if you see that this one, will they be able to offer 10 to 15 lakh for that surgery which may not improve? See, like if you ask me, like I will pay you 15 lakhs, this one tone should everything become normal. So I'll tell like chance 50% chance it may this thing. So then all the burden like after head injury or any stroke it happens, right? There is nothing like only one point is injured. He's unconscious for a certain period. He is in the ICU. We are giving on aspirin. All those things actually. It's a burden, financial burden. Already it has happened over a period of time. Then we think of stimulating actually. Then still like that type of usually we don't go for it.
Thank you, sir.
Difficult for us also, like quite challenging for us to handle a kind of stroke with heavy neglect, even traumatic brain injury with heavy spatial neglect patients. So I need to know like how it helps this transcranial magnetic stimulation.
As I explained, neuroplasticity kind of.
Okay.
See, like there is a certain aspect. For example, like we want he's got like left side brain is damaged. The thing. So there is a what we call as a connection. Corpus callosum is a connection. There is a right brain which is there. So like whatever we are utilizing, our neurons which are getting utilized actually, it is a broad area. This thing. Like there is nothing like one particular area which is causing weakness. So this is like earlier we used to mark, like for example, this is the Broca's area, this is speech area. If this gets damaged, so his speech is gone. So this is audition, auditory component. This is like legs, this thing. Even the marking has been done for our representation, but it is not like that actually. So there is a broader areas actually this one. So for example, like you expect like there is a Broca's area. Broca's area is particularly for the language and this thing. So if that area is damaged, so if you expect to have a aphasic this thing, but patient is not aphasic, so he's doing fine. So there is some understanding problem in ourself, right? So even though that area which is damaged, so he's completely fine. He's not having any language issues. So that means that there is nothing like one pinpoint area. So if it gets damaged, it will this one. But absolutely, this one, like if those who have aphasic kind of a thing, so if you stimulate those areas which may help in is improving is the thing. So if you stimulate them, but it's not like 100%. As I told you, it's not 100%. Like if you just stimulate them, you ask the brain cells to take up the aphasic function. So it won't happen like that actually. But sorry, continue.
Is there any particular time to give this transcranial magnetic stimulation to help the semi-spatial neglect?
Yeah. But right now, whatever you are doing, like initially, this one patient has to be very conscious state. So to do all these things actually, like it will be like the head injury has happened and he is out of this thing, and he has particular disability which is assessed after like some 3 weeks or 1 week. This one, and then you go for it.
Is there any other methods to fix it initially?
Pardon?
Is there any other methods rather than this magnetic stimulation?
Fix the problem earlier.
Yes.
See, earlier there is an issue. So, see, each injury is like it is a particular person to person variations actually. See, like one head injury, for us it is one patient is different from the other. Even though CT scan, they may look particularly like kind of 100% similar also, their problems are different. You see. So, and one with the same injury, one patient may be conscious enough, while other people will be in a bedridden state, intubated, all these things. So it's all like person to person. Like how he improves over a period of a time, like after 10 days or 20 days, you see, you assess it actually, like how is he doing. So accordingly, you can go for it.
Good.
Any other questions? Yes.
So, lot of questions for sir actually. So, yeah. Sir, I'm Srinivas Nayak from NIMHANS. I work in Physiotherapy Center there. So, my question is like, in your clinical expertise, what kind of challenges you face actually whenever you're treating this, whenever patients are on the path of recovery, what are the challenging aspects for the rehab team? And do you involve the family members? If so, in what way?
See, for us, family members are important from the day one itself. See, what we see is like there is some problems in the corporate, and problem is like in the ICU care itself. So we should involve the attendants. Head injury is a longer problems actually. It's not like a 1 day or 2 day. But I'm telling you about those who are severe head injury, not the like minor traumas or something. They will get discharged in 2 or 3 days. So this, see, like if we don't involve the family, for example, like 3 weeks he is in the hospital ICU and you take him out and then you tell them that this is the hospital bill and he needs rehabilitation. So rehabilitation, there is 2 options. Either you go to rehabilitation center or you make it at home. So now the problem starts actually existing. So if you don't involve the attendants, they will not be confident enough to take that patient to this one. So you imagine the patient with tracheostomy, he is not moving, so his eyes are closed, he will be laying still, and you take him home and you start monitoring all these things. Is like that is the difficult part actually. So from the day one itself, we like as a protocol, like kind of explanation which we do as a what is the first thing is the understanding what is the problem after the thing. So if you don't tell them that so he will be there for longer time like this, so then it creates a problem. So from the day one itself, we have to make sure that you prepare them daily that he needs to be done like this, he needs to be done like this thing. So what we see is like those who are detached kind of attendants are there, their patients will not do good. This is a scenario we see there.
Challenges part, sir. Challenges, what are the challenges you face in your day-to-day practice?
Challenges is, that's what I do. Like, for example, attendants are very detached. See, like, they don't want to touch him actually. They don't want, because like, see, secretion will come in this thing. So, like they feel awkwardness kind of thing to handle the patient. So, this is, I'm telling you about the only the relatives, how they, for example, if you have a particular sister or brother or a father or a son, if it is there, then they do pretty good. They do pretty good actually. So they will take care of all the needs, like kind of like emotional support, everything they will give actually. So that's more important in a longer aspect.
So whenever the patient is presented to you at the initial visit, so what are the key factors you look into to predict the recovery at the first initial phase? What are the factors?
Yeah, first thing is our first thing. As any patient is there, we want to start making it alive. So if he wants to go alive, then only all the matters will come. There is a first thing we assess actually, like how is the severity, whether he needs surgical intervention or not. So once we decide that surgical intervention is done, like it's all immediately we have to do in a day one itself. So usually procedure, repeating the procedure, usually like what happens is like sometimes the bleed can happen day 2 or 3, then we may need to re-operate and so on. So we have to counsel the attendants regarding that. Like our initial this thing is like to save rather than functional aspect. Okay, so if we discuss the functional aspect, then it becomes a problematic. They will start asking like this, when he will run, sir? Okay? So I can't answer that question actually. So when he will run, sir, when he will start going to work. So our aspect will be on that. Like we will not be talking those aspects of the initial state itself. So those questions will become awkward to us. We can't answer those questions. So like nobody can this thing. So it is like predicting when his recovery will start on that day and this day, giving him dates actually. They want dates, but that we can't do it. So at least in the initial phase, we will tell them how the severity is there. So like usually like the head injuries get stabilized within like 10 days. That's right. So most of the surgeries, any complications, if it happens, it will happen within those 10 days. So we prepare them like that. So 10 days you don't ask for like whether he will survive or not. See. So at one point of the time we will also able to see that. Like initially we get a CT scan done. After 1 or 2 days we get one more CT scan done to see assess that is any increase in the contusion or increase in the edema usually. That is there or not. Like if once it becomes stabilized and it is started to regress, then we'll tell them like, so now this is the period, now we have to concentrate more on the rehabilitative measures. Like, see now if he comes out of the ICU, ventilator, this has to be done. So we'll prepare him for like, see how the patients, if he lies down for like, for longer time, this is the respiratory infection, how we will take care. Initially we are not doing it actually. So we'll tell them how we are keeping his lungs, keeping his bowel, keeping for the DVT purpose, what are we doing it actually. See? And the same thing, they have to do it over longer period.
Thank you, sir. Thank you for your patience listening all the questions and talking into detail. Thank you very much.
And patiently answering for all the questions that came from different friends. Thank you so much, sir. Over time. Can we have a big hand of applause for the same?
Thank you very much.
Dr. Ramesh has 18 plus years of experience as a renowned academician. He has publications on simulations of muscle activation patterns and done research in the system and apparatus for functional electrical stimulation. Currently, Sir is working as an associate professor at Department of Physiotherapy at Ramaiah Medical College. We are happy to have you in our midst, sir. Now, we may hear from Dr. Ramesh. Over to you, sir.
Kindly please introduce yourself and then ask the question that will be helpful for many. Over to you, sir. Thank you.
Good afternoon, everybody. Thank you for coming down to listen. And sorry for a little bit of a confusion that happened in all this computer technical stuff that we're not that good at it nowadays. So right. So this is the topic that I'll be trying to discuss today. I've named it Recent Advances in Upper Limb Rehab. We'll be focusing on stroke, but once I'll quickly go through the slides and then you could probably have a discussion on it. So let's start with a very basic event that when we say recent advances, we tend to see whether we are adding new things or are we correcting wrong things. So the question that you would generally come to mind is that that upper limb is a really, really complex event for all of us, and we do get a reasonable amount of outcomes with upper limb rehabilitation, but it's by far the most challenging part of a stroke we have, that we are not able to predict or develop good upper limb outcomes or get consistent upper limb outcomes. So a lot of the times the question that I get asked is that what is it that we can do, and are we doing something really wrong, right? So to answer either one as a yes or a no, we will do that maybe at the later one. But let me go through quickly as to what the experience has been generally in physiotherapy. I'll quickly run through it so that you get an idea of how others across the world have been doing it. So this is the gross evidence for most of the things that we use. So anything that says is A is reasonably low level and D is reasonably good level of evidence. So you'll see that a majority stays in either A or B, which means that whenever we try and do some therapy, there seems to be quite a bit of variability in outcomes, right? Which means that even if there is a hypothetical situation where you have two people with exactly the same clinical presentations, you would still get two different outcomes in those people, right? So that is as physiotherapists, that would be a problem for us, because that means we get into trouble with the repeatability of outcomes, right? And that's an issue that everybody is trying to solve. So if you look at the evidence, you'll see that most of the usual therapies that we use is covered, and most of them have a mid-level evidence that says that we are somewhere there, but we're not completely there yet. Right. So generally, this is a common question that we get asked when we're asking that should we follow a given approach or should we do whatever we want, the so-called eclectic approach to upper limb rehab. So what this picture says, on the left is all the therapies lifted, and the only thing that we need to worry is this black spot. This is a meta-analysis. So you see the diamond there, this is called the zero line. So if it is on the zero line, that means that therapy is a little 50-50. And if it is towards the left of the zero line, that means that therapy hasn't really been very effective in its use. And if it is to the right of the zero line, the more right the diamond is, the more bigger the diamond is, the stronger is the evidence. So this essentially is telling you that all mixed therapies, which means that if you are able to mix multiple therapies and then do your therapy, you are more likely to get a better outcome in upper limb rehabilitation, right? So I'm just giving you these so that this forms grounds for discussion later on, and then you could ask specifics later on, right? So the problem with us is this, right? Everybody likes a particular method or an approach, right? And that it's like saying that I think I really like everything from a screwdriver point of view, from hammer point of view. You know, in carpenter you see that everybody has a tool, right, that they like. Now the thing with that is that if you have just one tool to work with, right, everything looks like a nail to a guy with a hammer, right? So if you have one tool, then you like to use that tool for everything, right? And that's a common mistake that we tend to do in rehab, in upper rehab, especially since, you know, one of the things that you keep hearing in neuro rehab generally and specifically in upper limb rehab is the word approach, right? So which means that it's an open-ended event, right? Which means that there is room for interpretation. So they will not ask you what is the exact technique you are doing for this patient, because the technique would change for each patient. So we can't repeat techniques very effectively. So they will tell you that approach the patient in a certain manner. Now when you start approaching the patient in a certain manner, which is a completely open-ended event, you tend to get a little comfortable with that particular approach, and then that approach basically dominates your therapy, right? So if you like, for example, a roots approach, right, and you are getting results in it, you tend to use roots approach for everything, right? And that's not how roots meant it to be used, so obviously it's that thing, right? So if roots is your hammer, you will use roots on everything, right? That's been the issue, right? So why am I starting with these kind of slides? I'd like to impress upon you firstly that in the areas of stroke rehabilitation and the neuro rehabilitation in the last 20 years, we haven't got a groundbreaking change that has happened. A lot of the changes that have happened in the last couple of decades have been optimizations, right? So we need to understand where we started before we understand where we are going forward, right? So we need to develop that historical perspective to be able to understand where are we going to go forward in the next couple of decades and so on and so forth. Otherwise, it will be like replacing one hammer with another. It is still a hammer for you. You will still hit it the way a hammer would be used, which essentially means that you will still start using therapy too extensively, right? And that generally is been the problem for neuro rehab anyway, overall actually. So let's take a very quick historical look as to how this whole therapeutic systems evolved. You know, in 1920s, you know, we used to do these things called muscle re-education. We still do it. Anybody who's gone through second BPT will tell you that's your basic story, right? Everybody will tell you that you have to re-educate this muscle, right? The thing with the word re-education of muscle, we know that the muscles are not really sentient beings. You can't educate a muscle, right? There isn't anything to educate in a muscle. But that was the prevalent discussion of that time, where they did think that muscle is a sentient event and therefore the muscle could be re-educated. Now we know that the muscle is reasonably dumb and all the education that happens in the nervous system, and the muscle essentially responds rather than getting educated. But that philosophy of thought, the way it was the way it was philosophized and the way it was used, would tell that, you know, they use an educational approach to rehabilitation, right? So it's like you trying to teach a kid that this is the way to move your hand, and the kid learns, right? Now what if the kid doesn't learn? Then you're in trouble, because then you assume that if a kid were to be taught, the kid should be learning, right? Now if the kid isn't learning, now that philosophy fails. So the re-education failed there, right? If whatever your assumption is does not happen, then you cannot educate the muscle anymore. Next, of course, is the so-called sensory motor or physiological approaches that came on with Sharon and such. Everybody here comfortable with words like Sherrington and things like that, right? Yeah. So we know that these went a little more physiological in nature, and we focused on understanding it because they had just figured out what the homunculus actually does, and they had also figured out how homunculus interacts to develop movements and so on and so forth. So as the knowledge of movement increased, you started to say that yes, now we need to be a little more task oriented or function oriented, and then you start working towards the function of a given movement rather than the movement itself. So you are no longer thinking about a muscle. If you notice, like this isn't about the biceps or the triceps. This is about the biceps or the triceps, right? So you see a lot of outcomes that we use, we still stick somewhere here, right? Is the bicep straight? Is the biceps bent? Can this person touch his hand, touch his head? So on and so forth. So it's a slight movement towards it, but we understand that the muscle isn't the issue here. It is the nervous system, right? And that is the first acknowledgement. It took us close to 30 years. And then now we are moving into the function of the brain rather than that of the muscle, right? And we are not thinking about whether it's the motor cortex. We know that the motor cortex really down, right? We know that it needs all the systems to work, and it's not the cortex, it's the motor system. So that evolution changed therapy, and we got into these therapies, which is all your motor relearning approaches and CIMT approaches, task-oriented approaches, cognitive trainings, and so on and so forth, right? And your usual biomechanics approach, right? So now, after this, there hasn't been a dramatic shift in the understanding of neurophysiology or motor system analysis. So now has been the last couple of decades has been optimizations. We are now trying to optimize therapies that we have and see if we can arrange the same therapies in different combinations, right? Similar to your combination therapies in pharmacotherapeutics, and seeing which combination gives you a nicer, better outcome. So last couple of decades has been those of how do we, for example, put one therapy on top of each other. So if you have a patient of rehab, would you want to do upper limb in the morning, lower limb in the afternoon, or would you want to do roots in the morning and NDT in the afternoon? Or would you want to do NDT first and then roots? Then would you like to stretch and then strengthen, or would you like to strengthen and then stretch? You get where I'm coming from, right? If you've seen cases, you will understand. These are dilemmas that are coming up. So this, it has been researched actually quite extensively over the last couple of decades, and we are now coming to an understanding, going back as to how the brain functions rather than how the muscle functions. And I'm not trying to say that muscles are not important, but the focus is now being more towards what the brain does and how the automata or the automaticity of the brain works and how we can leverage, right? And that you will see in these approaches. And in the 20 onwards now, we are trying to optimize each of these therapies to see how we can leverage each. So if, for example, you're using robotic therapies because that's the flavor of the month and the year and so on, robotic therapy as such isn't really a therapy, it's application of a robot on an existing therapeutic method. Otherwise, robot is simply a machine, right? It's like your car. There is nothing called car therapy, right? It won't do anything, right? So it's really not so much different, right? It's just application of a robot into a therapy that you already thought out for the patients, which is one of the big problems that people tend to have confusions with anyway with robots. So let's try and see how we are organizing ourselves as far as the upper limb and lower limb is concerned. And we did have very good discussions with Dr. Deepak, right? As to how do we do things. So I'm more inclined now to go towards general neuro rehab because all the questions that happened were so much towards general neuro rehab. But I'd like to see if I can stick to upper limb, especially, right? So you divide everything into two approaches, right? In two ways to do it, right? We're not going into the pathology of it. If the discussions are too academic, I don't think that's the reason for we are here today. So there are two approaches you can look for. One is facilitatory, the other one is stimulation. Now, the idea of the facilitation is that the brain will do it, we just need to facilitate. Or actually, it's a converse philosophy. The philosophy being that if you facilitate, the brain will do it. Right? And that's been the philosophy. Therapies that go through are all these CAMT, FESS, sensory motor, strength training techniques. All of them have this underlying idea that if you were to try and facilitate, the brain would automatically pick that up and do whatever it's expected. The other one is the stimulation approach, which automatically assumes that your neurons aren't really active, and that's the reason why everything happens. And if you activate these neuronal pathways, networks, structures, whatever you call them, you would start developing the outcomes, the motor outcomes that you're looking for. So these are all these mental imagery, music therapy, VR therapies, all of them want to stimulate, within brackets, whatever they actually mean, stimulate the nervous system, right? So what my interest of today, because we have to finish it as quickly as we can, is whatever I have put it in glue, right? So I'll try to focus those because those are the ones that have been used to develop both knowledge as well as outcomes in the last decade or so. And these are, as they call it, the flavor of the decade, right? So everybody wants to get into virtual rehab and brain stim and functional stim, robots, and so on and so forth, right? So we'll just try to take a look at what each of them do, and for example, how is this useful therapy, and then maybe I'll leave that open for a discussion. If you have experience on patients or questions that you would like to discuss that with. So let's start with this study. The first one is on strength training, right? So there's been so much of discussion on should we really bother with everything? Can we take that stroke is a function of weakness and all you need to do is to strengthen the muscle? And if you believe the facilitatory approach, strength is by far the most facilitatory of all approaches. So if you were to strengthen a muscle and the muscle did get strengthened, it did not happen simply because the muscle became strong. It happened because the muscle connected to the nerve became more active, the nerve that's connected to the cord became more active, the cord that's connected to the brain became more active, and only after the complete network of the motor system became active did the muscle become strong. Now, since the muscle has become strong, it means all the neurophysiological support in the background should have worked. Otherwise, the muscle wouldn't have been strong at all, right? And that philosophy has been really, really prevalent in physiotherapists across, and a lot of them would swear and say, I don't really do anything, no approaches. I just go after the strength of the muscle. If the muscle strength improves, it means that the brain is changing, plasticity is happening, the cord is responding, the muscle is responding. I don't have to worry about it. So, Carolee Winstein et al. Have been working on this for quite some time to see if that really is the only way. So can we all focus our energies? And what they have come out with is that the way I would ask you to read this diagram is anything red is not so great and anything green is reasonably good, yellow is just okay. So which means that if you keep doing strengthening as your primary approach, right, to any outcomes, right? If you ask most people who do home visits, for example, they will say that with limited facilities, the only thing I can do is strengthening of a muscle. So I put him on strengthening, strength training, or functional strength training, or whatever else, right? So what happens if you do that? Motor function generally improves, which means your Fugl-Meyer scale will start to change. Your dexterity is kind of not going to change much because you're not really working at very minute level with strength, because strength is a brute event, whereas dexterity is a fine event. So the fine events don't change, so dexterity don't go much. ADLs, which are affected due to strength per se, is going to change. Any ADL that doesn't require strength as their primary function won't change. Spasticity will not change with strength because we now know that the pathways of spasticity and strength are not really the same, even though there's quite a bit of discussion on spasticity replacing strength and so on, which is far more academic for us at the moment. ROM will change because ROM is a function of strength, and muscle strength in itself will not change. So if you put your biceps, which you have strengthened over a month or 15 days, and take an evaluation of strength using some good empirical means, for example, put it in an isokinetic machine and then try it, you will see that the strength hasn't dramatically changed. But if you were to take a biopsy out of that muscle, put it under a microscope and look at what happens, you would probably see that there is reorganization, there is mild hypertrophy, but the majority of the gains you've got is reorganization at the cord and the cortical levels. And that's what's been giving you the changes in motor function and ROM rather than that of the brute strength of the muscle. So it does increase, but it doesn't increase as much or in linear association with the amount of effort you put to increase the muscle. Right? So if you did 10 repetitions every day and you expect the strength to move 1 RM up, you're not going to get that. Right? Because majority of the changes that are occurring isn't really at the muscle level, but more at the nervous system level. Right? Then VR, right? Everybody likes VR because it offloads the physiotherapist from doing a lot of the things. You move therapy from the therapist to the patient. So a lot of the therapies are hands-on approaches, right? You are, as physios, we're really proud of the skills that we have. It's all hands-on, right? So NDT, MRP, task-oriented, roots, they're all highly skilled approaches. You need to train a lot, right? VR shifts all that onto your patient. So the patient does that and you are a facilitator to that approach. So what happens if you do that? If you do virtual reality and you are adding NMES on top of it, you have a reasonable outcome. But majority of the things don't dramatically change if you let VR run VR on its own, right? So if you take a very fancy 1 crore plus virtual rehabilitation, push the patient in and say, do whatever the machine says, you are going to get at best a yellow or a red. You're not going to get a green, right? Which means that on its own, VR is not really very useful, right? And but if you add therapies such as cyclic NMS is you put it on a cycle, you put an FES that understands what cycling is, and it will make the person do the cycle. You're functioning at a task-oriented level, right? And you probably will get a green on your RCT, right? And only FES without using TFES, introduce that. So task-oriented FES. If you don't do a task-oriented FES and you do a dumb FES, you're not going to get a lot of response, right? Because once again, it looks like the nervous system responds to really specific events. Now, RTMS is, it was a rage about 10 years ago, and every big conference you go to used RTMS. Nowadays that has slowly tapered off. So the difference between direct TMS and RTMS is you use a magnet over the area, regional stimulation of that, far more high frequency. We know there are two types of TMS. One is transcranial direct stimulation, it's simply using galvanism across your foreheads, and that's TDCS. And RTMS is using a coil on the area of the brain that you want to stimulate, and then you hit it with something like a 1.8 Tesla magnetic field, and you get depolarization of all those neurons, say, within that local neuronal pool. The whole thing gets activated. It's like putting a small grenade into your brain, hoping that it will wake up all the people around that area. Right? So what happens? Low frequency RTMS, that's in the range of 12 to 15 hertz. Motor function increases because we know that in the penumbra region, Dr. Deepak explained that a lot of these are in inhibitory phase. You hit it with a high intensity magnetic coil, it induces an electrical current, and you get the penumbra region to wake up, activate, depolarize. It causes a sequence of a cascade of events which improves the ability of the excitatory neurons and so on, and you do get reasonable motor functions, gross motor function. Dexterity starts to increase because most of the dexterity involves cortical involvement, which means dexterity is a pure cortical function. So because you are depolarizing the cortex, dexterity responds to it. ADLs respond reasonably well, but spasticity, ROM don't change because spasticity and ROM, both of them are mostly spinal driven movements. So it doesn't respond to RTMS. And anything that can be stimulated to cut the short, that has a direct cortical connection. So we know that, for example, the hand area, you can trace the axon of the hand area all the way until it hits your small muscles. So it means that there is a direct connection. And when you want the dexterous activity, that area of the hand really needs to light up before you can get the dexterity. So RTMS uses that and therefore picks it up. High frequency TMS, which is above 25 hertz, generally moves too fast to depolarize the top layer, so it goes into the bottom couple of layers of the brain. And you get changes in dexterities and ADL, and the mechanisms aren't really clearly known as to why that happens. Maybe involving it activates maybe BG loops or the posterior thalamic loops, and then develops some movement, and therefore maybe dexterity and ADLs will change. But the rest of them don't really respond. There isn't any data on spasticity and ROM. Bilateral TMS, which means you put two coils instead of one, right, and use the corpus callosal connections to activate. You don't get too much. So more is not more in this case as far as RTMS is concerned. So it used to be very expensive. Nowadays it's reasonably cheaper. So it seems to be interesting thing to do. Transcranial direct stimulation is simply anodal galvanism or cathodal galvanism. It's really a very nice, cheap equipment that you can get. You just put two electrodes on the forehead and pass a galvanic stimulation, like how you would do it for your de-innervated muscles in second BBD. You do something similar to that, and this galvanic current, as it moves, causes a field that activates activates neurons, across the electrical field that it puts, and it causes changes. Some of these changes have been in the range of maybe sensory inputs, maybe because you generally use the forehead and the areas that may be slightly near there. Anodal TDCS, not much evidence. Cathodal TDCS, not much evidence. Dual TCDCS, you have two on each side with the center channel. You get some motor function, you get some dexterity, the rest of it do not change. So how do you read this? This is a subtle event. If you are looking for a dramatic change in your motor function, don't go to TCDS, right? So both VR and TCDS are subtle events, right? You've got 90% of function, you want to push that 10% of function in your patient, you would want to go towards these subtle events, right? If you want gross changes in function, you want something slightly more potent, right? Tele-rehabilitation is a common event that everybody has been. You know, nothing really changes. Tele-rehabilitation is mostly a behavioral intervention rather than a physical intervention. So if your patient has issues and these issues are driven by behavior, your tele-rehab is going to be really useful. But if it is a pure motor deficit and the patient's behavior isn't really a function where the patient's already motivated, you're probably not going to get much out of it, which is a sad thing for us because that is the closest we can get from working from home case scenario, and it doesn't look like we'll be working from home in the near future based on what we are seeing as evidence to tele-rehabilitation. So I guess that's kind of what sums up as to what's been happening with upper limb rehabilitation. It's too complex for me to be able to say that, this is how you get the hand back, this is how you get the shoulder back or the elbow back, because none of those really work. Right? We have to work at an approach level even today. So over the last how many donkeys years I've been in this field, I've got a few things that I think I should share with you. The first one is that we need to start using our knowledge of motor control, right? Second, without a local event happening, nothing happens out here, right? You need to control your local factors. Use all these complementary adjunct therapies such as robots and virtual realities or whatever else comes up, FES, things like that. Use them judiciously. They are optimizations. They are, at this moment at least, they are not absolute replacements for any of the other therapies that are there, right? They may become the way it is going. You just need to make, like how a car can drive itself, maybe a robot can become a therapist. Maybe, it may be possible, but as of today, it isn't, right? So don't bend too much over onto a robot that looks really fancy. It's really just a simple machine, right? And motor learning, relearning happens. Whatever you do, it happens, but not just the way you want plasticity to be driven, right? But it happens, right? Take it as a given, right? You intervene in any way to any patient, regardless, there will be a change in his motor status. The brain is a sensory seeking event. It logs feedback. It will pick whatever input you give, motor, sensory, cognitive behavior. It will rewire itself. The point is not that, the point is how. So we'll go on each. I'll just try to explain what I mean for each. First is that let's start using the function of motor control. As physiotherapists, we spend a lot of time learning about the control of the muscles by movement, right? So by that condition, we're not really focused on the anatomy of the brain, we're more focused on the physiology of the brain, right? And the way the brain controls movement is really dealt with in the field of physiotherapy. But we don't seem to be using that knowledge as much as we like the anatomy of it, right? Right. So we need to start using motor control a lot more, especially with the movement, right? Upper limb is a really complex event, and you will see if you look at the range of or the variability of strength of each of our upper muscles, it's about 10 times more than that of a lower group of muscles, right? So if you want to walk, your quadriceps has to be able to take about 100 kilograms. I haven't seen anybody who can walk when a quadriceps can take 50 kilograms at the age of anything about 25. Right? There isn't much variability. If your quads drops below 50 kilograms of force, you're no longer walking. It doesn't really matter who you are. Right? But that isn't really true for your upper limb. You can have very little power and still retain majority of your motor function. Right? And that's a take home that you will have to see. That strength isn't really proportional to function all the time. That's what even the evidence tells us. So if it isn't strength, it's probably the way the brain controls movement. Right? So you have to be able to leverage that knowledge of motor control, right? And use motor control to develop your outcomes. Next, as I said, nothing global without local, right? So the hierarchical theory of motor organization works, right? Which means that if there is disinhibition by the cortex, your spinal cord will activate its reflexes. You will get hyperreflexia, hypertonicity, and so on and so forth, right? Which means that there is a hierarchy, may not be as much as we previously believed, and everything is hierarchical, and you always have to do it in a certain way. That's not true anymore, but the hierarchy anatomically exists and you have to respect that. Which essentially means that the local control, what is the position of the wrist matters to the brain, right? It doesn't care about it, that's what I'm saying, but it matters, right? So if you have a spastic flexor component, it matters because the spastic flexor component alters the sensory feedback to the cortex and it changes the way the brain starts to command. It changes, right? And that means that not everything happens up here. A lot of what you need to do has to get sorted first at the local level before you get a global activity. So you want that person to reach out, you should get the hand to be in a reach out position. Otherwise, he's not going to be able to reach out, right? So you can do that 100 times and he won't reach out because the brain's getting altered input from the brain. So you get your local stories altered. So if you have, just for example, a tight flexor component, you work on it, release that, make it ready for a reach out, and then you go to the brain and say, now that I have all this sorted, reach out. Right? There is no point reaching out when the hand is in this position. There is really no point because the brain isn't really learning anything new. It already knows how to reach out in this position because that's what the patient's been doing anyway. Right? The brain really does not control us by muscles, right? It sends a very gross move your hand kind of a scenario, right? Which essentially means that the cord will do. I'm humanizing a lot of these just so that it's easy for us to understand, but the cord won't do anything with that. It's no longer sentient. But the cortex isn't really worried too much about what are the specifics of the movement. But it will get feedback on the quality of the movement. We know, right? The cerebellar loops, the BG loops, all of them give information to the brain on the quality of this movement, right? And the brain really doesn't care about the specifics of it. So you want the brain to move, it gives you a movement command, right? It's not going to give you what the wrist should do, right? Unless you are looking for a dexterity movement, right? Then that's a different discussion. Then proximal musculature dictates what happens downstream. So if you have a spastic scapula, it will change what happens in your elbow. Right? It will change it. You really cannot have a discussion of the elbow without discussing the scapula. Somebody discussed what happens to the red nucleus. We know, for example, that 70% of inputs of the motor or the motor output of the red nucleus goes into controlling the scapulae, right? And upper part of the upper trapezius, the scapulae, and some parts of the longismus, right? So if that hasn't been in control, and if the red nucleus has no inhibitory control up from either the subthalamic or the lentiform, you know that the fellow scapula is always going to be stuck. And with a stuck scapula, the length tension relationships cross will change. You will get spasticity of the biceps, and he will not respond to anything you do, any of the therapies you have, because every time you stimulate or you do therapy or you do whatever it takes, it goes through and then the scapula blocks that afferent impulse and sends some other impulse up. And the brain says, it did not do what I asked it to do. I'm not going to change. Right? So you have to get the proximal musculature intact before you go up all the way to the brain. So it seems to be a hierarchical event. Right? If you're going motor, you have to start at the most proximal joint, get your business sorted all the way to the least proximal joint. And the sensory pathways, you start from the least proximal joint and go up all the way to the most proximal joint. Right? And that's probably a more useful way. I'm not going to say it's the better way of doing things, but it's probably going to be the more useful way of doing things. Use all these complementary therapies judiciously. Right? What do I mean by the word judiciously? Like these robotics, right? With the cyclical, you will see this in a postgraduate, just trying out the cyclical FES that you have, right? You can also connect NMES and whatever else, right? Now this is going to send massive amounts of sensory information that tells the brain that a movement is happening. It doesn't do anything to the brain. What does the brain want to know? The brain wants to know that a task is being done, right? It's the task that picks the amygdala, it's the task that retains your movement, it's the task that drives your happy and muscles, right? So if you haven't planned out, this is simply a fancy cycle, it won't really do anything to your patient. Your patient will really feel nice. The hands will be very much supple because the local loops are all worked up quite nicely. The muscle tone will start to reduce, which is a change in motor function. But there is not going to be any carryover effects because you haven't taught the brain anything, you have just altered the sensory motor loops at the spinal cord. Right? FES is actually, if you combine this, you have a better chance. This alone, you will have to go into task-related FES or FES that are directed towards one specific area or one specific task, right? And you figured out that this is not a function of strength because FES doesn't do anything to strength, and it's a function of control, right? And then you are trying to alter everything in functions of control. Now, we've already discussed a little about TDCS. It's simply galvanism. So you are really good at galvanic stimulation. So whatever happens, it's a very subtle effect. So if you have behavioral issues, if your patient has low motivation, we know that TDCS has improved motivation levels and such. I really am not sure about the mechanisms. Biofeedback. You know that biofeedback helps because brain is a sensory seeking organ. So you give it the right kind of feedback, it responds. And that is a truism, and there isn't a time where you give it the right feedback and the brain doesn't respond. It can happen in coma stimulation or your end rehab patient. It's all the same to the brain, right? But what kind of biofeedback is a big question mark because we haven't figured those pathways out yet as well as we should have to make it a very potent weapon. But it is actually quite a potent weapon in your tool set. But at the moment, we don't seem to know how to use it very well. Motor learning, relearning happens. It will happen because of all the things I just said, but it needs to be driven, right? Motor learning doesn't happen the way you want it just because you are thinking of doing everything right. You have to do what the patient brain wants you to do. You have to activate the right pathways, you have to drive the right kind of movement, you have to drive it in a very specific manner, right? And then you get motor relearning to happen the way you want it. Will it happen without you doing all this? Absolutely yes. But it is not going to do it the way you want it to happen. So the equilibrium point hypothesis, if any of you are postgraduates or going to be postgraduates, there's a hypothesis that's been evolving called the equilibrium point hypothesis, which says that the brain simply looking to find out what's the best and the easiest way to do this to achieve an equilibrium state. And it means that it will learn to come to that state, right? And it will do that regardless of what you're doing, regardless of what you're doing, right? But if you want to change therapy, you want to, your patient was moving his upper limb in a certain manner, his shoulder was abducting, and you'd like it to not abduct, you have to figure out what is the change and drive the change specifically to avoid an abduction movement. Right? You can't simply say, no, if I were to give my hand like this, it will change. It won't. Right? That's not how the brain seems to work at least. So you have to be far more focused to drive change the way you want to change. Right? Brain learns mostly by reinforcement, which means you have to tell the brain whether it has done the right thing or the wrong thing. Non-reinforcement learning is mostly at the subcortical level, and you're not really in a very good position to drive non-reinforcement learning. So you have to learn good reinforcement methods. So you have to go back to your Pavlov's conditioning techniques and stuff so that you know exactly what to drive, what to reinforce and what not to reinforce to drive motor learning. Plasticity is a basic mechanism. You really can't do anything about plasticity, right? You can drive plasticity, but there isn't really anything in the toolkit of a physiotherapist that can actually influence plasticity without going through behavior or motor learning. There isn't anything there, right? So you have to take care of these two. And movement is behavior, right? There are experts who will come here and convince you that movement is simply another behavior of the brain, and there are mechanisms of reinforcement and of behavior, right? But I would challenge you to make a person teach how to stand, whatever the word teach means, if the patient doesn't want to. Right? That's not going to happen. Right? Which essentially means that, but you take the RTMS and hit him, his muscle will twitch, whether the patient wants to or he doesn't want to. Am I correct in that? Right? You hit it with a magnetic coil, the muscle will twitch. Right? That's not going to change. You don't need. The patient will be comatose. You take your coil and fire and he will fire. But you can't do that to a patient who doesn't want to stand. He's not going to learn to stand up, which means behavior is a very big deal for us, right? And there are experts in the West who love this behavior concept and would like to see everything as a behavioral component. They're not terribly wrong, I would say, right? So that's what we mean by using the word motor learning, right? Drive it. Without driving, you're not going to probably get it.
Sir, when we talk about stroke rehab, basically we have lots of interventions, but the time at which the intervention should be focused, the time of intervention, the intensity, the dosage, the literature doesn't give much evidence on that. And the evidence is rapidly changing also. If you just consider, see, acute stroke, so there is earlier we were focusing on early rehabilitation. But right now, our trial says that doesn't help, and that is going to have an adverse effect on your stroke recovery also. So, what is your take on the intensity, intensity and the dosage, and at what point the intervention, if it is focused, would have a greater recovery?
intensity matters. When let's try and take that into physiology, right? So let's say that we did this in Nimhan's. You have a fantastic neuroscience department. So if you were to take a neuron and start exercising the neuron, how would you do this? You would put maybe one drop of acetylcholine and then the neuron is activated for a certain period of time. So if you translate this all the way back, all your movement by the time it reaches to neurons is either an excitatory stimulus or an inhibitory stimulus, right? So very early in post-injury, there will be this lucid interval where there aren't enough neurochemicals, just to put it grossly, that if you deplete them very quickly, you go into a hyperpolarization state. And from there to come back to a normal polarization is going to take a longer time, right? So in the really early stages, that's why the evidence isn't really sure as to what's the intensity of treatment. Would you not want to intervene in in a neurological condition? You have to intervene as early as you can in a neurological condition, right? Because this inhibitory excitatory cycle moves both ways, right? You can have extreme inhibition or extreme excitation, and with the right amount of input, you could keep the balance so that as the person recovers from that acute insult, you will be able to pick the patient at a much higher level, right? That's actually easier said than done because we don't really have really accurate values as to what level of intensity of therapy is required. But there is really no discussion where we would say that there is an acute patient and I don't want to intervene him on day 1 or 2 or something like that. Assuming that there is homeostasis. If the patient is not in homeostasis, then there is a discussion that's easy. I am ICU, neuro ICU in charge. So we intervene as long as the patient is stable medically. We intervene right away with the most minimalistic of movement, most minimalistic of stimulation. But not a lot at all. But there is really no discussion, there is really no rationale either from a physiological perspective or a pathological perspective that we shouldn't do it. You have to. There is enough evidence, there is enough logic to suggest that you should intervene very early in the process and you should intervene but a little more judiciously to ensure that. So if your patient's GCS is dropping and you give him the right kind of stimulation, you're actually bringing up the right. To the extent that now, for example, if the patient is sedated on propofol and that's not great because you're really pushing the system down with these sedatives, so you may actually want to discuss with your anesthetist and get the sedations altered so that they are more rehab friendly sedatives, so that your brain is able to process that input, so that when if and when he comes out of that sedation, you will pick him up at a slightly higher level. So you will take him out of your ICU a couple of days earlier perhaps, right? Or maybe out of the wards a couple of days earlier. That's a big win, right? If you can bring the ICU stay down by 1.5 to 2 days, that's quite a hit actually.
And in one of the slides you mentioned that your intervention is some orthopedic, so I would like to know.
It's mostly a mechanical or biomechanical view of life, right? So one part of system says that it's everything biomechanics, right? But of course, it's not really called biomechanics anymore, it's called neuromechanics or neurobiomechanics, or whatever it's called. So you could go with a reasonably mechanistic view of things and still achieve reasonable outcomes, right? So you don't have to be a neurophysiotherapist sometimes to intervene to be really good, right? You just need to know enough logic to be able to apply and say, okay, I know what the muscle is, I know what the bone is, I know what the nerve is, and I know how to strengthen a muscle because I was in a gym and the gym teacher taught me how to strengthen a muscle. The elements are really reasonably there. You you might actually get some output. And it was a push in the 90s, so I thought I'll just make sure. It's there, but you may not get to output.
Thank you. Thank you.
I'm Ananya from Aditya College of Physiotherapy. First of all, it was a really great session. I got to know a lot of things from a different perspective. So moving on to my doubt, I've seen stroke patients from my post-graduation, and the problem is when we see a chronic stroke patient and an acute stroke patient, the goals that the patients give us, like if they want to walk, for example, the function is walking. You are able to achieve the function of walking irrespective of whether the patient is coming to us in the earlier stage or even if in the later stages. But why is the function of buttoning your shirt is achievable in the acute stage but not when the patient is coming to us after 2 to 3 years later?
Well, your observations are right, but your conclusions are not. Right? There is no evidence to suggest that a 2.5-year-old chronic patient cannot get the outcomes. He can. Right? Now, the thing is that as the time progresses, as I said, the person's nervous system adapts and develops its own networks. The networks are now completely different when compared to what he was in the acute stage. So you would have to probably go do a lot of, if you are into motor learning technology, you have to unlearn a lot and then get it to relearn, which is a complicated issue, and we don't really know how unlearning actually can be done. So Caroline Weinstein et al. Did this 10-year study on accelerated learning and unlearning methods. I don't think they've still published it, but they've been doing some work on it. It involves everything. For example, you could unlearn, one of the ways you can do it is by hyperpolarization. You put an RTMS to a spastic area and it kind of hyperpolarizes and the patient loses movement. Then you start retraining him. Maybe that's an approach, right? But there is no experimental evidence to suggest that that's the best way forward. But now they are exploring. That's why I thought that this decade is going to be optimization, how to layer one therapy on top of the other. But there is really nothing to suggest that at the end of I can show you successes in Ramaiah where a 3-year-old person has walked, has done buttoning of the shirt, and so on and so forth. Right? This is not to say that regardless of the area of injury, those things matter. The type of lesion, the area of lesion, whether it's grey or white, is it cortical, subcortical, brainstem, they do have an impact on the level of recovery, but from a purely physiological perspective, it's possible. It's possible to get it back, right? I hope. I didn't confuse you too much there.
Thank you.
Thank you, sir. My name is Subbu, and full of interesting points in presentation. And my specific questions are related to 2-3 areas, but one I want to start off with is the ROM, range of motion. So there are a lot of technologies out there which are calculating, assessing range of motion, and I wanted to understand from you how effective is treating ROM in terms of overall rehab or movement health in general.
Let me rephrase that and say that ROM is not really an outcome for us, right? ROM is an orthopedic outcome. From a neuro perspective, function is an outcome for us, right? So how effective is an intervention in ROM? It depends on what is the level of impairment due to ROM, right? And if ROM is really the only impediment, then it's not really a neuro case, it's mostly an ortho case. And there are far more effective ways to deal with ROM orthopedically than using neurologically. So if, for example, it's a very highly spastic muscle and that's impeding ROM, you can simply give a Botox, right? Or get a tendon release and you get the ROM right there. You've got your function right there, right? So that's how I would think of ROM activity.
Because in the table of wherever we have mentioned the greens, yellows, and the reds, So there is RM, there is dexterity, there is...
Yeah, it is an outcome. So when you want, as a physiotherapist, when you want to do activities, your patient is thinking that I should get everything. He doesn't like that the hand is not moving to full extension, right? So for the patient, that's one of the goals that he would come to you with. Because this may be aesthetic for him, this may be functional for him, but it's a goal. So we are obligated to address and acknowledge that, but that isn't really the focus of therapy.
Okay.
Yeah.
And thank you. And another question is related to the quality of movement. In terms of, you spoke about, I'm sorry, mindful movement and other things. So when you consider movement as a behavior, do you see that, the modern concepts of mindful movement, embodied movement, and aspects like we are starting to see this uphill increase in terms of dance movement therapy, creative movement therapy. So these modalities, what are the effectiveness of these modalities in terms of, because I see there is this task-based, the FES thing, which is like, okay, can you lift this up 10 times a day? Okay, and then now you're successful. On the other hand, it's also about having intention to lift. Like, I have an intent to lift this. So this intent, expressiveness, how can it actually change the effectiveness of the therapy?
Tough question, but I'll tell you that music therapy, I'm not, I haven't put some thought into music, but I can tell you about dance therapies or for that matter, slightly less skillful than dance is, for example, yoga as a therapy. So these are all purposeful movements, and purposeful movements are better than non-purposeful movements. Right. But if there is a neuro rehabilitation dance, it would be more better than neuro rehabilitation, right? But just dance isn't really going to give you specific outcomes. It can give you generic outcomes. The patient had difficulty walking 10 steps. After dance, he walks 10 steps. Is a reasonable outcome because you're bringing in all the behavioral aspects, the motor aspects, and everything else. But if you want your hand to go out and grasp glass, I don't think there is a dance for that. Right? So similar in yoga, for example. So yoga has been found to be fantastic. We've actually got a grant to see how much yoga can be used in neuro rehabilitation. But we know that yoga is not meant to be a neuro-rehabilitative procedure. It can be purposed to some extent, like dance, like music, but it cannot be a therapy. Okay, at least that's what I feel.
Okay. So because
all the things you said matter, absolutely, 100% it matters, right? But if it is that real subtle changes that you're looking for, I mean, if a person were to come and ask that I'm taking therapy with you, can I also go and do some dance therapy? I wouldn't say no, absolutely. There is nothing to say that is harmful. Right. So that's absolutely fine. There's no problem. But if he says, I'll disconnect from you, I'd rather pay a dance teacher, then I would be a little worried, right? So, in many ways actually. Right. But that I don't think is a good idea. Right? So we don't really know what is the actual level at which these things intervene and how, see, in the end, anything is therapy, anything can be called therapy. You go sit in a room full of steam, they call it steam therapy. So, but that's really wrong to say. When you want to therapeuticize something, you need to be able to get the effects on demand. If you can't get this effect on, it's maybe a slightly more academic discussion, but there are things that qualify and say that this is therapy, right? Yeah. So sometimes I fit with the colleagues to say that you guys are not really doing exercise therapy, you're using exercise as a skill, right? And it's not really therapeutic in nature. So that way music or dance or anything can be fantastic for the patient in many ways, but I don't think they qualify as therapies at the moment. I just have the problem of that word therapy, because the word therapy, including some of the things that we do as physiotherapists and call it therapy, right? Like FES therapy. FES is at the moment not therapy per se, right? So that is where all the problems lie. If you don't use that and say, is music beneficial? Absolutely. At least in my experience. A lot of my patients say, can I also go to a gym? I think you're doing exercises. I can also do exercises on absolutely no issues, right? Can I stop coming here and then go to a gym? That to me is a little bit of a problem, because that may be exercise, but it's not therapeutic in nature, right? It doesn't have all the things that qualifies it as therapy.
Like having metrics.
Yeah, I mean, there are things that cause a therapy to be called a therapy.
Okay, all right.
Music doesn't have it, so not for neuro rehabilitation.
It's very subjective in terms of interpretation. That's why.
It's not subjective. It's simply not there yet, right? So if somebody says I'll do Bharatanatyam and it'll improve my balance, I would be willing to accept, right? Because it's really a intense thing to do Bharatanatyam, and it requires all the faculties to come in, and it will improve balance, right? I'm doing the study on Bharatanatyam and balance and Bharatanatyam and yoga for the Department of Science, right? But if you say that Bharatanatyam therapy happens, that I'm going to say no, right? Because it's not therapeutic. It's more of a positive side effect.
Okay.
Right? So I'm not saying I discourage. Please encourage your people. The more variability of work, the better their outcome is. There is really nothing to discourage anything that is an active process.
Sure.
Right? So if your patient comes and says, I know there is this salt therapy, you go sit in a room full of salt and it will improve it, I have a problem with something like that. But if he says, I'll jump in the salt therapy unit, I'll say, go ahead, do it. That's not a problem, because there is going to be some benefit of it. Right? So you shouldn't add the word therapy to stuff. Apart from it, I think it's all fine. It's fantastic. I have no problems actually.
Thank you, sir. So one last question. It's about the quality of movement. So is it like we already have in our system inbuilt that okay, this is good quality of movement, this is bad quality of movement. Okay, I think I'm not moving well. So is this a feedback in a normal or a slow person that actually happens on like just all time?
Yeah. So patient perceived quality, there are quality scales that says as a physiotherapist, my goals are to get him to do something, but the patient may want to do it differently. Like you don't want to go for you're in a party and you want to take a glass of water, you don't want to take it like that. You want to take it graciously. You want to fit into the image that the society wants it. For the patient, all of these are goals. For me, the ability to hold a glass and drink is a goal, because I'm thinking without drinking a glass, he becomes dependent, his survival is involved, and so on. So I look at the patient a little differently. The patient looks at these things a little differently. So the patient-oriented goal system needs to be taken into consideration, but I would not make it the primary goal of therapy. But sure, if you achieved a functional goal,
yeah,
you could go for the quality, absolutely.
Okay, quality is that feedback happens naturally, and as per the capability of the person, they can go on improving.
Well, you can help him. You can use, for example, the task-oriented FES. You could use any other therapies that you have. You could use robots, right? And you could develop the quality, right? The patient's able to hold it, but he isn't able to hold it well. His timing is off a little bit. It makes him look a little awkward. Robots are fantastic at getting your timing right. So you put him on a robot, get your therapy sorted, and you'll get the timing.
Okay.
So you get the quality, the patient feels really nice and happy about it.
Okay.
Right? Or you take him into an FES loop and you get him to work the quality of movement. And a task-oriented FES, a really good one, should be able to do that. And the patient feels better, he feels faster, better. He is more socially active. There now people are working to find out. It's not really as a physiotherapist I am to gross an intervention for that. But if you speak to an occupational therapist, for example. They're interested in how quickly can somebody pick a cup of water. Is it socially acceptable time to pick a cup of water and so on. But anyway, so there is an intervention, there is an assessment for that, but it's not really my area. Okay. So I draw my line at the time at which the guy gets function. If he wants to do it very beautifully, then probably you should reach out to an occupational therapist or something to do that. But for the patient, I think it's really important. So if you are going back to work and you have to turn a knob and it takes you 10 seconds to turn a knob, then you are not going to go back to work. They will say, sorry, this is not done. Right? So somebody has to do that for the patient. I think an occupational therapist is far more suited to do these kinds of jobs, but it's somebody's job. It's important.
Right. Thank you. Very elaborate. Thank you, sir.
Good afternoon, sir. My name is Mansoor. I work in Suvitas. Sir, we work in rehab. I have seen many patients. See, maximum take it 100 patients are there. Patients come there. When we make them walk easily, but hand function is always a question mark. So that see, for saying, for thinking, by seeing many things are there, sir. We directly say that lower limb will come easily. Lower limb will come comparing to upper limb easily, sir. But lower limb, upper limb is lot of question marks. Sir. So before we used to think that in cerebral cortex the homunculus is there, in that hand region and the face region is very big, so that it will take more time to get a fine motor control. But lower limb don't have more fine motor controls, and lower limb contains very big muscles, so that motor pulls are very more compared to upper limb. So walking will be very nice. We think like that, sir. Sir, upper limb, lower limb having both same neurons, no change in the neurons. Okay, now the damage happened in the cerebral cortex. Okay. Now my question is that upper limb, lower limb having the same neurons, but the motor pulls, the connection between muscle and the nervous system is more in the lower limb because of very big muscles. In hand, they are small muscles, sir. So I am asking you, what is your experience? You have done you have seen many patients, sir. What you feel like this technique, this protocol will be nice for the upper limb? Your experience, sir.
Which technique? Sorry, I kind of lost the question. Which technique were you discussing?
Sir, I'm asking your experience, sir. You have done, you have seen the patient.
So this answer doesn't require, like, I wouldn't agree with a lot of the things you said about the number of neurons. I don't know what that reference is from, but it's not about just the number of nerves and neurons that a muscle connects to. It's the amount of real estate the brain, the area has, right? So if it needs one neuron to control a muscle or 100 neurons to control a muscle, right? And that, if you feel that it is the same in the upper limb and the lower limb, then you're wrong, right? The upper limb requires more, maybe 5 times more number of neurons to control dexterity than to walk, right? So whether how many neurons go or not go is really the last part of the equation, right? So motor control is about how much resource a brain requires to control a given movement. As I just said, the brain doesn't really care about the muscle at all, right? So the spinal cord is more interested in all these things. The brain doesn't really care.
So starting you said that the lower limb has big muscles, and the upper limb has short muscles. Can you why you said the difference, sir? Can you say that why?
Meaning, lower limb has
big muscle. Yeah.
Big, right? Quadriceps, hamstrings, they are bigger than biceps and triceps.
Yeah.
Right?
Yeah. My question is same, sir. These have lower limb having big muscles, quadriceps, hamstrings, so that their recovery is very fast. See, in the lower limb also, if we compare this.
You are asking why is lower limb faster in recovery compared to the upper limb?
No, that I understood, sir. That I understood. My question is that here difference is between big muscles and short muscles.
Weak muscles and
small muscles, sir.
Small.
This upper limb has very short muscles comparing to lower limb, sir. So I am asking your experience, sir. See, everyone have different ideas, sir. Everyone have different therapies, sir. Your experience, it is useful for the short muscles, sir. This we can stimulate easily. Anything like that?
No, no. We don't know exactly how this thing works because it is upper limb is complex. It's more complex than lower limbs. The reference I'm going to give you is the function of what are called central pattern generators. Maybe you could go back and understand the spinal mechanisms that drive the leg and the spinal mechanisms that drive the hand, right? So maybe there is something there. But other than that, the amount of cortical control of the hand is much higher than the amount of cortical control of the lower limb. That may explain why that it is slightly more easier to recover lower limbs than the upper limb. I mean, it's simply a hypothesis. I could be really wrong. You can come at it from multiple angles to explain about it. You could say that lower limb is more controlled by the brainstem, which doesn't require the cortex. You can come at it multiple angles to answer this question. But I think a short answer I would say is that the amount of control the spinal mechanisms has on the lower limb is far higher. You can actually make a person walk without having really any cortical control, which means your spinal mechanisms are reasonably good enough to get majority of the movement. But I don't think you can get that person, whoever you are discussing about, to play football, because that involves dexterity of the lower limb, which is very, very complex. So I think if you bring dexterity and cortical control in, upper limb and lower limb will be having the same amount of difficulty, right? But because the spinal mechanisms are more advanced to get walking, and walking is a reasonably simple task when compared to the dexterous activities of the upper limb, the spinal mechanisms are not that great in the upper limb, and probably, I'm not saying this is the reason, probably this may be the reason why it is slightly more difficult to get upper limb than lower limb. How do you intervene in something like that? Is by ensuring that you don't rely on spinal mechanisms when you're doing upper limb activity. You bring in the cortex right at the beginning, right? Second way I feel you should intervene is that the upper limb depends on the trunk. If your trunk is not sorted, your upper limb is not sorted. As physiotherapists, we never really care much about the trunk at all, right? So, for example, a 2-degree change in the scapula alters the change of the biceps as well as the forearm flexors. A 2-degree change in the position of the scapula, right? So, which means that where the scapula is in a given position may really influence what the elbow can do or what the shoulder can do. Now, we as physios don't really go so deep into upper limb because we see the hand and we go after the hand. We see the elbow and we go after the elbow. We don't worry too much about what the trunk is doing, what the neck is doing, because these are the proximal for these and they influence it. There is no reason to, that's not even for discussion. But we don't do it much. Whereas we instinctively try to strengthen the gluteus because we know that it's the gluteus that works. Gluteus happens to be the proximal for the lower limb. So maybe you are simply doing the right things with the lower limb and the wrong things with the upper limb.
Sir,
Does that answer the question?
Yeah. Sir, I understood, sir. I understood.
Who was concerned to be in our midst. My sincere thanks to Dr. Deepak, Dr. Ramesh, who has given us highly intellectual talk.